So next I would like to invite Dr. Anurag Mishra, an excellent orator and director of Radha Raman Hospital and a live surgeon in almost all conferences. Welcome, sir.
Thank you so much, Praful. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. Recently, I'll just go through this small rigmarole considering a patient of mine. I was asked to evaluate a diffraction-free multifocal IOL very recently, and I did. Post-operatively, the patient was very happy. 6.6 N6 was the outcome. I subjected the patient, as I always do, to the examination or evaluation under an eye trace. It plotted a VS-OTF curve for me, and this was the result. Look at the depth of focus, massive, 4.26 diopters. Obviously, the patient will have a 6.6 N6, but look at the peak of the curve. It stays at 0.1 logmar visual acuity. For me, anything on the VS-OTF curve where the peak stays below 0.5 is absolutely unacceptable when it comes to quality of vision. So what should we do? If we want a combination of defocus, some amount of it at least, and the quality of vision, enhanced monofocals are the way to go. There are different technologies that go into manufacturing those. Some of those IOLs add on spherical aberration and defocus it. Some of them change the spherical curvature profile on the anterior surface and achieve it. The IOL that I'm talking about is a Vivinex Impress coming in from Hoya. What it does is something very, very interesting in the central 2 millimeters. It employs what's known as free-form optics. Now, if you have an anterior surface which is flat or aspheric, and you play around on the surface geometry to your liking, it's known as free-form. There are two lenses in the market which do it. Vivinex Impress is one of them. And what it does is, in the central 2 millimeters, you have a profile, something looking like this. This is a schema of that. So you have a convex anterior and a concave anterior merged with one another in the central 2 millimeters. The points where they meet with each other is known as the inflection point. The convex obviously will converge it more. The concave will diverge it. And outside the 2 millimeters, you have the base curve of the lens, the base refractive power of the lens. So you have a point focus, you have a diverging ray, you have a converging ray, expanding it into some sort of a line, producing the defocus. The defocus that is produced by this is an enhanced monofocal IOL, so it's obviously not going to be close to a trifocal, but the defocus that it provides is quite consistent, and that is what I need to see in my patients, consistent defocus, based on which I can pitch the product to my patient. I can tell them confidently that this is where you're going to land. You will need some assistance for your near vision though, but your intermediate is going to be helped if this lens goes into the practice, goes into your eye. This is something interesting. In terms of the pupil size, when you take in the mesopic pupil, where the light is less and the pupils dilated, the line improvement is not much. It's hardly 0.7. Having said that, in a mesopic condition, you actually don't need intermediate vision to come in. You need the distance vision to be dominant there. Vis-a-vis that, the photopic pupil, you have a significant line improvement by 1.2. In contrast to that, when a photopic pupil dilates, there are people whose preoperative pupil size is more, even under photopic conditions. There, you have a significant improvement. When the light is more, it produces defocus better. But under mesopic conditions, when the pupil is large, it does not give you the defocus because we don't need it. This is even more interesting, but this is something that almost all monofocal pluses have. The defocus is more in the myopic range. It gradually reduces when you go to the hypermetropic side of the eye. So accordingly, you should counsel your patients. If you have an axial length less, then the defocus will also be less. I'm not someone who speaks a lot with regards to published studies which come from the company's front. I basically base all my talks on my clinical experience. So let's look at one patient who was significantly young at age. All right? He came to me with this sort of a cataract. I didn't know for sure whether he had a history of trauma or not, but it was an intumescent cataract. I tried to salvage it. This patient wanted a trifocal to go in his eye, and didn't have. He was a corporate honcho, and he didn't have much of driving to do. So he wanted a trifocal, but this is what I had intraoperatively. I had extension of the rexis And while I was trying to salvage it in one eye and give a cut and revive it, the whole capsule opened and I had a typical Argentinian flag. So obviously, I carved out whatever remainder capsule I had in my hand and made it look like some sort of a rhexis and a window to me so that I can do the rest of the procedure. Thankfully, the ergonomics of the incision was such that I could avoid the weakest portion of the capsule. This is what all of us would do in such a situation: minimal hydro, minimal rotation, and then start phacoing it, taking care in every step that the stress should not be on the weakest point where it has extended onto the periphery, keeping an eye on the fluttering flap, making sure that it was not extended and not gone beyond the equator. One by one, all the fragments removed. Now, this patient had opted for a trifocal. I changed my decision intraoperatively, obviously. This patient was not suitable for a trifocal anymore. I implanted a Vivinex Impress, made sure that, since this is not a toric, so made sure that the haptics remain under maximum capsular coverage, and then fashioned a flap from either end and tried to convert it into a rhexis so that we have a circular opening which is aesthetically looking much better, and then from both sides it could be done, and the IL was sitting nicely. Post-operatively, what came was interesting. Okay, this is the VS-OTF curve, and I have not changed the name of the patient in every slide of mine so that you will be sure that I have not doctored this. Okay, this was the VS-OTF curve. Comes out in every implant of Vivinex Impress. The peak lies well above 0.5, and the depth of focus is consistently above 0.9. So came with this patient. Fine. This is the MTF curve. Same patient, same name. Well above the critical 40% at 10 cycles per degree. Excellent contrast provided to the patient. Next came the DLI, the dysfunctional lens index. 10 on 10. Perfect. Same patient. Next came the central 1 millimeter scan. And as you can see here, I did not render the patient myopic, which a lot of monofocal pluses or enhanced monofocals advise you to do. Leave the patient slightly myopic so that a bit of defocus is added on. Not with Impress. Next came, this is actually the punchline, the encircled energy function. What does it indicate? It indicates how much of light that passes through the IOL is actually available to the retina. 99% as a total.
You're out of time.
5 seconds. Yeah. 5 seconds, sir. And finally came the magic slide, same name again, magic slide of point spread function. Look at the focus, how sharply defined it is. I just showed you that the patient has a defocus of 1 diopters, which means that he would need a 1.5 addition for achieving N6 at near, but yet the point spread function shows you how clearly defined the image quality or how sharp the image quality is going to be in the fovea with the same name in the same patient. Nothing more to prove. My case is rested. Thank you so much for your attention.
Thank you so much, sir. Yes. Yes, sir. Please.
Dr. Mishra, I have used eye trace a lot, and I have done MTF of different lenses.
So can you use the mic, sir?
You are using long instrument for analyzing diffractive lenses.
This is not a diffractive lens.
This is not, but what you have shown for the first lens that you showed,
That's not a diffractive lens either.
that is a diffractive lens.
No, that's not.
That is what?
It's a lens which has come very recently to the market. They say that they have changed the refractive index of the IOL material. They have split the optic into 2 halves. One is for distance up above and one is for near down below.
Leave that aside. What ray tracing is doing, it is a single ray goes, it comes back, and it is analyzed for the deformation. Right? So if you have a diffractive lens and you measure a eye trace for that, so none of the ray that would come back would be very well focused, because the impact of the diffraction comes after positive interference. And
Agreed.
in eye trace, you are not using positive interference.
No, you don't have to use positive interference with the machine, sir. The
Yes,
positive
sir.
interference
Just
is...
understand, sir. Please, please.
No, I'm not disputing you.
And because any diffractive lens would not give you good MTF on eye.
I was actually extending what you're saying. I was supporting what you're saying. And I'm just going a step beyond. Yeah, you finish off.
Just tell me, what is the maximum MTF that you have got in any best monofocal eye?
1.
No. Which one?
Carry on.
No.
Should I show you?
Yeah.
Should I
can
show you?
Me. I have done lot of.
Should I show you?
The
I have the figure with me, sir.
The best I have got, is 0.85, and that has come with.
The best I have got is shoots beyond 1.
Sir, even the company doesn't say.
Well,
I don't know what the company says, sir. I'm showing you the
debates
slides.
are
If you're interested,
essential,
you give it 10 seconds to me. Then sir, I agree with you that the diffractive IOLs will never ever cause a 0.1 or a 1's VSOTF curve. Let's understand two things first. One, the visual Strel optical transfer function curve does not take into account the MTF. It's a balance between the point spread function and the depth of focus. Two, I agree with you. None of the diffractive IOLs will produce a good MTF, but there is a limit. The limit is set at 0.5. That's the reason why I said 0.5. Anything below 0.5 is not acceptable to me. It might be to you, but it's not. I'm not using the wrong instrument. I'm using the right instrument, and I do have my differentiations where to look for and to not accept a product as producing good visual quality. I have my own standard set.
Thanks, Dr. Anurag. I think the discussion is going on. We are short of time. It's a very interesting discussion. Would definitely like to go further, but because the other speakers are also in line. Thanks a lot, Dr. Anurag. Thank you very